Thank you for the opportunity to be here to talk to you about multiple myeloma, and thanks for the nice introduction. I'm going to talk about the new consensus guidelines for diagnosis and response in multiple myeloma. I'm going to go over an overview first, and then we're going to go over the new guidelines for diagnosis, response, and then I'll take any questions. As you know, multiple myeloma is a hematologic malignancy that affects the bone marrow of patients and also the bones. And it is associated with multiple morbidity and mortality. There are about 100,000 new cases worldwide and about 72,000 deaths. The cases of myeloma are also expected to increase significantly in the next few years, mainly due to an aging population and possibly also to better diagnosis tools. The incidence rate of multiple myeloma in Asia is around 0.5 to 3 for every 100,000 people, and the average age of diagnosis is around 62 years of age. In North America, the incidence is higher. It's about 6.3 of every 100,000 people. It is higher also in African Americans, and the age of diagnosis is a little bit longer, usually around 69, 70 years of age. This plasma cell malignancy is marked by molecular heterogeneity. As you all know, not all myeloma is created equal. And there is a natural history of progression from MGUS and smoldering myeloma, which creates a unique opportunity to study this disease. Currently, the definition for myeloma requiring treatment requires that the patient has evidence of end organ damage or biomarkers of malignancy. And you have the biomarkers of malignancy listed here, and we'll go over them in a little bit more detail in the next few slides. You also have some subgroups through gene expression that detail the heterogeneity of myeloma. I also wanted to point out that we do have a new revised international staging system that is based on more than 4,000 patients from 11 international clinical trials. This was truly an international effort to do a new staging system for myeloma. This is based on 3,000 young and elderly patients that had data also for the international staging system, which is the older staging system that we used until a few years ago. LDH and cytogenetic abnormalities. And these patients were treated with modern era medications with immunomodulatory drugs and proteasome inhibitors, and the median follow-up was 46 months. And what you can see here is that the staging is based on the albumin, the beta-2 microglobulin, cytogenetics abnormalities, including FISH, and also LDH. And if you don't have any high-risk cytogenetic abnormalities, you have a serum albumin of more or equal than 3.5 and a beta-2 microglobulin of less than 3.5 with a normal serum LDH, then you're low risk. And if you have a beta-2 microglobulin of more than 5.5, any high-risk cytogenetics, which are defined as deletion 17p, translocation 414, or translocation 1416, or a high serum LDH, then your ISS is stage 3. And if you have anything in between, then you're stage 2. And you can see the overall survival for 5 years in stage 1 is 82% compared to 40% in stage 3. So this staging gives you an opportunity to identify those patients that do not have good prognosis and maybe to do some difference in the treatment so that they can have better outcomes. So it is an important staging system to all your patients using the clinic to stage them according to this. So we'll talk about the new guidelines for diagnosis. So this is a little schema here. Let me see if you can see. Okay. So this is the tumor burden from less to more. We've talked about MGUS and smoldering myeloma being natural precursors of multiple myeloma that needs treatment. And so the definitions have been in the past a little bit arbitrary based on studies of progression. So a long time ago, I think Dr. Kyle figured out that if patients had less than 3 grams per deciliter in the blood of M protein, less than 10% plasma cells, and no end organ damage, the risk of progression was significantly different than those patients that had an M protein that was more than 3 grams, that had more than 500 milligrams of protein in the urine. These are the monoclonal proteins, more than 10% plasma cells. And based on this was crudely differentiated into MGUS and smoldering. With time, we've figured out that this smoldering myeloma is actually also very heterogeneous, with subpopulations of patients that have lower risk to progression, very similar to MGUS, and some patients that are very similar to myeloma. And so the new definition for diagnosis takes into account these patients with smoldering myeloma that are close to this line here, where they would have myeloma requiring treatment, but they have not yet developed end organ damage. So for the diagnosis after the guidelines published in 2014, the main difference is that there have been some biomarkers that have been identified through different studies, mostly retrospective studies, showing that these patients that have, for example, more than 60% plasma cells in the marrow, that have an involved-uninvolved free light chain ratio of more or equal than 100, or more than one lesion on MRI that can be identified as myeloma, these patients have a risk of progression that is around 70–80% at 2 years. And through a consensus guidelines, it was decided that these patients should now be treated as myeloma. So any patients that have these biomarkers here should be myeloma. And on the contrary, patients with smoldering myeloma up to, I guess, 59%, although you can see this is also a little bit arbitrary, right? 59 is almost the same as 60, but you have to put the cutoff somewhere. So 10 to 59% plasma cells is still smoldering, okay? And you have the criteria here. I don't know if you have the slides, but, and basically these are the main changes. And this is just one slide reminding us of this definition of MGUS and smoldering. For smoldering myeloma, the average for transformation to myeloma is about, for 5 years, is about 50%. Again, there are some patients that do not progress here. Most of them do, but some of them do not. This is a very long-term follow-up, 25 years. So sometimes it's difficult to predict the individual risk. This is one of these publications that talked about having more or equal than 60% bone marrow plasma cells. So this was a publication from a retrospective study from the Mayo Clinic a few years ago that was published as a letter. And what the authors from the Mayo Clinic saw is that when they looked back to about 650 patients with smoldering myeloma, and they looked at specifically this biomarker of the percentage of plasma cells in the bone marrow, the ones that had less than 60% plasma cells progressed at a much lower rate than the ones that had more or equal than 60%. What you can see here is most patients that do have, 60% plasma cells in the marrow, most of the times they already have CRAB criteria. They already have the kidney dysfunction, or usually they have anemia. So it's a very small percentage of patients that have this degree of burden in the bone marrow and actually have not yet developed any symptoms from this. It's a very small proportion. It's 2–3% of all the patients. And this is what you see here. And I believe, there have been other studies published also later on after this was published, saying a similar thing, that it's also a small percentage of patients that they do progress quicker. The next one is the involved divided by the uninvolved free light chain ratio. So this is if you have a IgG kappa myeloma. This is the kappa by the lambda. If you have an IgG lambda, it's the lambda divided by the kappa. And it has to be equal or more than 100. What you see here is for those patients that had this biomarker that was more than 100, the time to progression, in this case, was around 70% at 2 years. And then this is the study showing that if you had more than one lesions on whole body MRI, that also this portended a significantly increased risk of progressing to myeloma in the following 24 months. And basically all of these 3 biomarkers, what they show is that the risk of myeloma is too high so that we would just establish treatment beforehand. So this is why the diagnosis for myeloma changed. So in summary, before 2014, what we used for myeloma that required treatment was the CRAB criteria, and after 2014, we're using still the CRAB criteria, but also biomarkers of malignancy. We're also going to go over the new guidelines for response very briefly. Why do we need new definition for response assessment for myeloma? Well, this is due to the fact that we have deeper responses with the novel medications, and we also have the need to assess for minimal residual disease. Using all therapies, even with an autologous stem cell transplant, patients did not achieve complete remissions in most occasions. It was definitely less than 50%. But now using the novel therapies up front, using consolidation and maintenance, definitely more than 50% of patients achieve a complete remission. However, even those patients that have a complete remission, they still relapse, and this suggests that there is persistent disease that we cannot detect with the current recommended guidelines. And so these new guidelines were made so that we can go a little bit deeper, assessing minimal residual disease. In this response assessment, there really has been no change in the definitions of progressive disease, stable disease, minimal response, partial response, very good partial response, complete response, and stringent complete response. The only thing perhaps in progressive disease or relapse is that now there's a category that if you're minimal residual disease negative, then you can turn into minimal residual disease positive, and that will be considered relapse, but it is not a clinical relapse. So there is no recommendation to treat if you go from MRD CR, MRD negative to CR, MRD positive. There has been a big change in minimal residual disease criteria, which is the first time that we have this in myeloma. And there are basically 4 categories: a sustained MRD negative, flow MRD negative, sequencing MRD negative, and imaging plus MRD negative. These are basically the standard criteria that have been published very recently. And here you can see that this is very similar to what we've been using in the clinic, at least in our clinic at MD Anderson. And you can read this, but basically if you have a complete response, you have negative immunofixation and urine disappearance and any soft tissues plasmacytomas, and less than 5% plasma cells in the bone marrow. What we call a stringent complete response requires all of these things in the complete response, but then also that the plasma cells in the bone marrow cannot be clonal. And then you also need a normal ratio in the serum free light chains. For the minimal residual disease criteria, I'm just going to go over here a little bit. So sustained MRD is when you measure minimal residual disease in the bone marrow by next generation flow or next generation sequencing or both, and also by imaging, with this definition where there is a disappearance of every area of increased tracer uptake found at baseline or a preceding PET-CT. And then and this has to be for a minimum of 1 year. And then the subsequent evaluations, you can say 1 year MRD negative, 2 years MRD negative, 3 years, and so on. By flow, they have put this definition where there cannot be any aberrant clonal plasma cells. As you know, by flow cytometry, you can detect in a very sensitive way, especially with next generation flow, the number of aberrant versus normal plasma cells in the bone marrow, and this can be reported in the regular pathology report. Here, they want us to use the Euroflow standard operation procedure or similar or equivalent method. So there are currently 2 methods. One is the Euroflow, which uses 2 tubes, 8-color flow cytometry. And then there's another one that we're also using, which is a 10-color flow cytometry, 1 tube. And they both have a sensitivity of around to basically found 1 in 10 to 5 cells that could be myeloma. For sequencing MRD negative, you need to have absence of clonal plasma cells by next-generation sequencing on the bone marrow aspirate. The presence of a clone is defined here as less than 2 identical sequencing reads obtained after DNA sequencing of bone marrow aspirates, using lymphocyte, platform, or an equivalent method. And the minimum sensitivity is also 1 in 10 to 5 cells. So currently, we're not using sequencing at MD Anderson for minimal residual disease detection. However, there have been many studies showing that the sensitivity of sequencing is better than flow cytometry. So we are actually working now to get sequencing at MD Anderson, and currently what we do is minimal residual disease flow. So far, it is not changing what we do if the patient is MRD positive or negative. For example, if a patient finishes transplant and consolidation treatment and then their CR MRD positive or MRD negative, we still give them maintenance to both of them. So I think that in the future, I'm not sure if this is going to change, and there are many ongoing studies now evaluating what is the role of minimal residual disease in the treatment, to see if treatment needs to be stopped early if you're a minimal residual disease negative, if you need more treatment if you're positive, and so on. For imaging, we do use a lot PET CTs, especially to detect. Sometimes there is hidden disease. If a patient is going to transplant and they have had prior extramedullary disease, we usually check a PET CT to make sure that there's nothing left before they go to transplant. In this case, for the criteria, you need to have disappearance of tracer uptake for myeloma for a patient to call them incomplete remission, basically. And for that, you either have to do a PET CT at diagnosis or at relapse, when they relapse, and then if they have any areas of uptake in the bone marrow, or if they have lesions somewhere else, or extramedullary disease, those have to go away. And it's actually the PET CT, I do think it's very useful for myeloma. There are actually several studies, I believe at ASH also, there was a publication talking about the usefulness of PET CT in myeloma. And it's something that we use quite a lot. Okay, any questions about this? No.
New England Journal of Medicine. Everyone, please give a warm welcome to Professor Orlowski.
Thanks very much. I'm going to tell you a little bit about how to think about treating your newly diagnosed patient who could be eligible for stem cell transplant based on some of the available regimens, mostly with a focus on some of the drugs available in the US, but as I mentioned earlier, many of these are now becoming available more generally. These are actually the updated NCCN guidelines for transplant-eligible patients with myeloma. And the interesting thing is that even though we have more drugs now available, the number of options has actually decreased a little bit, if you remember from the past, because you'll see that the preferred regimens now are just 3: bortezomib with cyclophosphamide and dexamethasone, or bortezomib with doxorubicin and dex, or bortezomib with lenalidomide and dex. And some of the category 1 recommendations have actually been moved down to less preferred or other regimens, including things like bortezomib with thalidomide and dexamethasone, and the 2-drug combos, bortez and dex and len and dex. So I thought I would just go through some of the data that really support the various recommendations. There have been lots of studies looking at CyBorD in myeloma, and I didn't want to go through all of them, but this is just one which showed that it has a very good response rate, usually 75 to 90% of patients. And it does have the advantage that in most places cyclophosphamide is relatively cheap and therefore easier to give than perhaps more expensive drugs like lenalidomide and thalidomide. The interesting thing about it still being preferred is that there was an abstract not at 2016 but at 2015 ASH where the French compared CyBorD to bortezomib, thalidomide, and dexamethasone. And what they found is that after 4 cycles, this is not until progression, after just 4 cycles, that the bortezomib, thalidomide, and dexamethasone had a better overall response rate and also a better VGPR rate or better. And so in some ways, if you're only going to do 4 cycles of therapy, it may be that CyBorD is not your best choice. And the adverse events were what you would expect, a little bit more cytopenias with the cyclophosphamide, but more GI and neuropathy events with thalidomide. One of the options as category 1 and preferred is bortezomib with doxorubicin and dex. And I'm sure you remember the Dutch and German trial, which showed that if you gave bortezomib with doxorubicin and dex, then transplant, and then bortezomib maintenance, you had a better overall outcome, especially if you had a deletion of 17p, which a little bit answers some of the questions that Dr. Lin asked earlier about that subgroup. The most recent data, this paper was actually just published within the past few weeks, which was the SWOG study that compared lenalidomide and dex versus bortezomib, lenalidomide and dex, both given for 8 cycles. And then on both arms, patients went on to get lenalidomide and dex as a maintenance. And you probably know the data showing that VRD had a better progression-free survival, and this was both in transplant-eligible as well as transplant-ineligible patients. And interestingly, the survival data were better as well, which is a little bit surprising considering that they only got maximally 8 cycles of a bortezomib-containing therapy before going on to len and dex. And if you look at the response rate and quality, you'll see that the overall response rate was better if you got the 8 cycles of bortezomib-containing therapy, and there was also a trend towards a better, very good partial remission. Other combos that are up there, bortezomib and dex, this is just one of the studies that compared, for example, VD to the old standard VAD and found that it was at least as good, if not better. And then bortezomib, thalidomide, and dexamethasone, which again has been studied by many groups, including the Italians, who showed a better event-free and progression-free survival, which was maintained after transplant, which tells you that the better your upfront therapy is before transplant, the better will be the outcome after transplant. Lenalidomide and dex was down there as one of the other regimens, and again, a number of studies, but this one from ECOG was very instructive because it compared len with high-dose dex to len with low-dose dex and showed that the low-dose dex regimen was at least as good and maybe a little bit better in terms of survival. And that was exciting because usually in oncology, we think that if a little bit is good, more has to be better. And in fact, here the opposite was true. You could do just as well or better with less therapy, in this case with less dexamethasone. One new combination that made it onto the list is actually ixazomib with lenalidomide and dexamethasone. This is interesting because although you know that IRD is approved in the relapsed setting in the US, it hasn't yet been approved for newly diagnosed patients. But because of this phase 1/2 study with an all-oral regimen, which showed that there was a good overall response rate, and you can see that about 27% of patients had a complete remission after 12 cycles with a very well-tolerated oral regimen. This was in part what led to that being listed as an option. And you can see from this waterfall plot that quite a few patients had a 100% reduction, and many more had a 90% or more and a 50% or more induction benefit. And of course, although ixazomib is a new drug and will probably be a little bit expensive to start with, the flip side is that because it's oral, it could ultimately be cheaper because you don't have to administer the drug intravenously or subcutaneously. You don't have to get the pharmacy involved. You don't have to get the nurses involved. You don't have to bring the patient to your clinic. And so ultimately, from a cost-benefit perspective, this may be something to look at. Now, carfilzomib with len and dexamethasone was included in that, and this is based initially on Andrzej Jakubowiak's work, where they were able to show that there was quite a nice, almost 100% response rate with this combination. and a high rate of stringent complete remission, suggesting that maybe KRD could be better than VRD. And this is being tested now in the US by a cooperative group study, which is comparing VRD to KRD head-to-head. And I think that probably KRD will be better, although you may remember that there was a press release from the study in transplant-ineligible patients which compared bortezomib, melphalan, and prednisone to carfilzomib, melphalan, and prednisone. And in that study, there wasn't a difference in outcomes. So we can't assume that we know what the results will be. Additional data about KRD were presented at this past year's ASH meeting from the French group. They did KRD as an induction, then they did transplant, and then they did KRD as a consolidation. And they found overall, you can see 57% of patients had a stringent complete response, and a large proportion of patients were also MRD negative, both by flow as well as by next generation sequencing, which again suggests that maybe KRD will be very attractive. And the more therapy that you got, as you can imagine, the better was the quality of the response. The main issues were that there were some cardiac events, and this is something that is a pattern with carfilzomib. The rates are low, but they are there, and this is something which we're studying in more detail to try to understand whether some patients have a higher risk than others. And cardiac and pulmonary toxicity is broken out here. You can see that there were a small number of events of cardiac failure, pulmonary embolism, and cardiac arrhythmias, which is certainly something to watch for. One of the interesting things from the SWOG study I mentioned earlier, and you could probably show these curves from any trial, is that the quality of the response led to a better outcome. Meaning if you had a VGPR or greater, you had a better progression-free and overall survival than if you had a PR or than if you had stable disease. And so that raises the question of whether some kind of response-adapted therapy may be the best way to go. And there was one study presented at ASH, which was the MRC11 trial, that was kind of interesting. What they did is, you can see they randomized patients to get either cyclophosphamide, thalidomide, and dex, or cyclophosphamide with lenalidomide and dex. If patients got a VGPR or CR, they went on to transplant. But if they got a PR or MR, or stable or progressive disease, they could get randomized to either no further therapy or to addition of bortezomib with cyclophosphamide and dexamethasone. If you look at the here column that says after CVD induction, you can see that those patients who got Cybor-D after the IMID regimen had almost a 40% improvement in the quality of their response, and this was maintained after stem cell transplant. And when you look at the long-term outcomes, you can see that progression-free survival was much better if you got the Cybor-D than if you did not, although overall survival was not yet different. But that's not unusual in these transplant-related studies where it can take a little bit more time to go ahead and see a difference. But you can see in the subgroup analysis that if you got Cybor-D added, virtually every group of patients did better, suggesting that maybe what you need to plan on is 4 cycles of induction. If you have a great response, keep going to transplant. But if your response is sort of then maybe you need to add a different combination with additional novel drugs. And here again are the transplant-eligible data that show good outcomes. And as you can imagine, the toxicity of adding the CyBorD was mostly in the thrombocytopenia and neutropenia category. Now, I also was asked to look at 2, 3, or 4 drugs, and right now there aren't that many studies really that looked at 4 drugs as induction. One of them was this evolution study from Shaji Kumar, which was a relatively small study, so I think it's tough to make too many conclusions, but they randomized patients to get either bortezomib len and dex, CyBorD, at 2 different doses of cyclophosphamide, or the 4-drug combo of bortezomib, len, cyclophosphamide, and dexamethasone. These are the progression-free survival data, and actually it looked like the bortezomib, len, and dex, which is the top curve, did a little bit better, although this was not statistically significant. And these were the overall survival data, but in both of these, the 4-drug combination did not do better, whereas, again, if you look at the response rates here, the VDCR in the middle had a trend towards maybe no difference in response rate, and yet the toxicity was greater, so you're not really benefiting there. And then this study, although it wasn't for transplant-eligible patients, but it's one of the few other trials that looks at 4 drugs versus 3 drugs, even there it wasn't straight up because this was Antonio Palumbo's study where he did VMP versus VMPT, and the VMPT patients got VT afterwards, whereas the VMP people did not. And if you look at 54 weeks of induction, you do see a small difference in outcome, but if you're thinking about 4 cycles of induction therapy, it doesn't look like 4 cycles of 4 drugs is going to be better than 4 cycles of 3 drugs. Other options, Jayton Shaw from our center has done a study with RVD and panabinostat, which showed a nice overall response rate, and after only 4 cycles, half of patients were MRD negative, so we're going to hopefully publish these data soon. And then through SWOG, we did a study for high-risk patients where we did RVD versus RVD plus elotuzumab. So far, the only thing we've been able to publish are toxicity data, but hopefully at this year's ASH, we'll be able to show some of the efficacy data. So I think the conclusions that I would leave you with are 2 drug combinations can be used in some cases. I think if you have an older patient or a patient with lots of comorbidity, or if cost is an issue or drug access, I think it's fine to do something like Lendex or bortezomib dex. But in general, 3-drug regimens are the current standard of care, and that could be a PI with an IMiD and a steroid, or a PI with an anthracycline or alkylating agent as a steroid. And adding a 4th drug right now, we really don't have enough data to really support doing that. I think the future challenges are we're going to start seeing data with an antibody, an IMiD, and a steroid induction, and it'll be interesting to see whether those are better, the same, or worse than a proteasome inhibitor, IMiD, and a steroid. And especially, I mentioned earlier that an oral proteasome inhibitor could be cheaper, so maybe that would win out. The other problem with 4-drug regimens is the cost. Given that the added cost is going to be much greater, I think the benefit will have to be substantially greater, not just like a 20% improvement. I think we really need a huge improvement to justify giving 4 drugs, although antibodies seem to be the best option because they add relatively less toxicity than, for example, an alkylating agent. And then the other question is, if we do 4 drugs, should we give 4 drugs up front? Or should we do, as I showed you, a treatment or risk-adapted approach? For example, maybe high-risk patients should get 4 drugs, and standard risk patients should get 3 drugs, or maybe you should do 3 drugs for 4 cycles, and if you don't have a good response, then you add the 4th drug. And these are things that hopefully we can all work together to try to answer, because although patients are doing a lot better, there are still many folks dying from myeloma, and hopefully we can do better than that. So thanks very much, and hopefully we have a couple of moments to answer questions if